Bismillah ar-Rahman ar-Rahim. I would like to thank you all for attending today for our second annual meeting for WEGE. I would like to thank the floor and thank the chairpersons, all of them. Today I will present a talk about the constipation and current treatment options. So these are my agenda. So we all know that constipation is a common gastrointestinal issue that defined by infrequent or difficult bowel movement. It affects the significant portion of the population, with prevalence estimating widely based on factors like age, geographic location, and diagnostic criteria. Constipation can impact the quality of life and lead to increased health care utilization. The estimated prevalence worldwide is 16%, and 33.5% was attributed to adults between 60 and 110 years old. So according to the American College of Gastroenterology, it is a symptom-based disorder defined as unsatisfactory defecation characterized by infrequent stool, difficult stool passage, or both. Difficult stool passage including straining, sense of difficulty during the defecation, incomplete evacuation, or hard and lumpy stool. Chronic constipation is also defined as the presence of these symptoms for more than 3 months. What are the types and etiology for constipation? We have different risk factors for constipation, like poor dietary habits, insufficient fluids and fiber diet, old age, gender, females are more prone, lower physical activities, poor bowel habits, like ignoring the urge to defecate, using certain medications, and certain diseases like systemic diabetes or neurological deficiencies. The types of constipation can be either primary constipation, which is functional, or secondary due to identifiable medical disease. Primary causes of constipation can be normal transit constipation, slow transit, pelvic floor dysfunction, dysenergetic defecation, or IBS, the constipation type. These are a diagram for the classification of the chronic constipation. Okay, it also constitutes the primary causes, which are functional, like motility disorders, functional constipation with normal transit or slow transit, functional defecation disorder, and constipation dominant IBS. The other arm is the secondary drug-induced constipation in anticholinergic drugs, tricyclic antidepressant, or antipsychotic drugs, opioid-induced constipation. We have also the systemic disease-associated constipation like diabetes mellitus, hypothyroidism, or systemic sclerosis, and organic disease-associated constipation like colorectal cancer. So the diagnosis of constipation can be algorithmic, also systematic diagnosis like any other disease, starting from the clinical history and symptoms, physical examination, which should include the PR examination, minimal laboratory tests to exclude medical causes, and colonoscopy is indicated in different indications, and also some specific tests to evaluate the constipation pathophysiology. As we see here, the ROM4 criteria has defined the constipation as a symptom of at least 6 months before diagnosis. These criteria should be met in the past 3 months. This is for the functional IBS-dominated constipation. 2 or more of the following should be present, like the straining, lumpy stool, and we see here the Bristol stool chart. Sensation of incomplete evacuation, sensation of anorectal obstruction, manual evacuation, fewer than 3 spontaneous defecation per week. If it's present for more than 25% of the defecation of this person, so he can be diagnosed with IBS constipation type. Physical examination, it should include the nervous system for spinal disorders. It should include the abdominal examination for any distension, any masses, any palpable colon masses, The perineum should not be ignored in the diagnosis of constipation. It should be observed at both rest and after the patient strains. Also, PR examination of utmost importance because it can diagnose any fecal impaction, strictures, or even rectal masses. The laboratory tests are also the basic laboratory tests, starting from CBC, thyroid stimulating hormone to check for hypothyroidism, serum calcium and electrolytes, also blood sugar to detect diabetes. This is a diagnostic algorithm for chronic constipation. It includes the alert symptoms, the clinical assessment, constipation symptoms, and this, if it exists more than 3 months, then the diagnosis of chronic constipation should be stated. In chronic constipation, usually it overlaps with the IBS constipation type. So in IBS, as we mentioned before, the presence of abdominal pain and discomfort that is either relieved by defecation or associated with altered bowel frequency. Symptoms are usually aggravated by eating or passage of mucus rectally. Colonoscopy should be indicated in the following cases. I will mention later. Radiology should also give some information about the baseline evaluation of colonic anatomy. Abdominal films can be the first line imaging to detect the retention of the stool or distension such as megacolon. It can also identify fecal impaction, bowel obstruction, and fecalith. So these are the red flags that indicate colonoscopy for any patient. Any patient above 50 years old, some guidelines say 45. Iron deficiency anemia, any refractory constipation is not responsive to medication. Any patient with rectal bleeding, weight loss, unexplained changes in the bowel habits, positive occult blood stool, family history of cancer, or family history of IBD. So colonoscopy, we all know, it can evaluate starting from IBD, masses, malignancy, stricture, even diverticular disease, or post-surgical problems. Diagnostic colonoscopies should be prioritized in patients with constipation who are at risk of colorectal malignancies. A specific test, we can only refer patients to these tests who don't respond normally to reasonable trials of empiric therapy. These tests are like colon transit testing. It measures the rate of which the stool moves through the colon. Balloon expansion test, simple office-based assessment. Anorectal manometry in some cases of the anorectal dyssynergies and problems, and sometimes defecography. How to manage the constipation? We have to exclude the anatomical causes, the metabolic causes. We have to treat the systemic diseases. We should induce a high fiber diet. Also, we should assess for motor function and pelvic floor problems. So this treatment of chronic constipation is a matter of patient education. Patient education in this case is of utmost importance about the dietary changes and also to control the drug therapy if the patient has a medical condition. Biofeedback therapy, sensory training, suppository programs are some of the management for the pelvic floor dysfunction. So patient education include reassurance, explanation of normal bowel habits, increased fluid and fiber intake, habit requirement with the use of normal postprandial increase in colonic motility by instructing the patient to defecate after meals. Dietary changes should include wheat bran, fiber found in citrus food, fruits, legumes, who stimulate the growth of colonic flora, and of course excess fluids. Laxatives are the conventional treatment for the constipation. They are subdivided into bulk laxatives, like increased fiber-based laxative, or osmotic laxatives like the lactulose, stimulant laxatives, and softener laxative. We can refer to surgery in very specific cases like repair of rectocele, Hirschsprung disease, and colectomy in chronic inertia. The new pharmacological options that Pharco are giving us today in the management of constipation is lubiprostone. Lubiprostone is a locally acting chloride channel activator. It enhances the chloride-rich intestinal fluid secretion without altering the sodium and potassium concentration in the serum. By increasing the intestinal fluid secretion, it increases the motility in the intestine, therapy facilitating the passage of the stool and alleviating symptoms associated with chronic constipation. So the dose adjusted in chronic constipation is 24 microgram, was approved by the FDA for the treatment of chronic idiopathic constipation and opioid-induced constipation. And in 2008, it was also permitted as 8 microgram, was approved by the DHA in irritable bowel disease with constipation. This also we can see here that it is a selective activator of the electrolyte type 2 chloride channel that resulting in chloride secretion in intestinal lumen, followed by water into the intestinal lumen and accelerate the stool transit. Some of the side effects it causes like nausea and diarrhea. In conclusion, overall, the average prevalence of constipation was estimated as 16% of the worldwide population, which is a very common problem. Secondary constipation is important, especially in the presence of alarm signs. Patient education and diet are very important iron management in the primary constipation. The medication of the new era used to with high clinical success rates like lubiprostone, brocalobride. Surgery should be indicated in very specific conditions, and also fiber intake. Lubiprostone, Lubicont, is an effective treatment for chronic constipation with high safety profile. And I thank you so much for your presence and your attention. Thank you.